5 different companies sending me job prospects for students all over the country. So that's always a good thing, especially as COVID's now opening up. 'Cause last year it kind of dried up a little bit, but that's looking
Yeah, I
good.
was gonna say like the last couple years has been dry.
Well, not for Echo. For Echo, we've had quite a bit until we went into COVID. COVID really did put a damper on it, but for Echo, it was pretty lots of job availability. Not in Spokane, but everywhere else, yes. But again,
That's still good news.
that is good news. Yeah, that means that there's jobs if you want them. And again, I do recommend when you graduate. I know you might want jobs in Spokane, but don't necessarily hold out for jobs in Spokane because the longer you go without hands on a transducer, the worse your outcome is. So, I would take a job wherever you can for a couple of years and then come back if that's what you want to do. Don't not scan because you're waiting. That is the kiss of death in this industry. Okay. I guess the alternative is you can always come back here and get your other certifications if you want to as well, like vascular for those that aren't already vascular techs. All right, get rid of that. All right, any questions before we get going? Diseases of the aorta today. Should be pretty straightforward. There's going to be a somewhat review on this just because we've covered aorta, at least abdominal aorta, and vascular. And so now we're just talking about thoracic and above. Well, everything thoracic, I guess. Let me start the Pinocchio. Okay, so this is just a 1-part lecture. There are 33 slides. So there's a chunk of slides, but again, it's going to be a lot of reviews. So it's not like it's going to take a ton of time. Make sure I see your faces as I'm lecturing. And screen share, that's what I need. Okay. There we go. Okay, so just got a picture up here. So I just want to review anatomy. We'll go into more of it here as we talk through the slides, but just note that the thoracic aorta is in sections or just defined as sections. So we have our aorta, which is the aortic valve. So then our aorta itself kind of starts really with the annulus. You got the sinuses of Valsalva, or the aortic root as it's called. We know that that's where the coronary arteries should take off. We have the sinotubular junction. So the sinotubular junction is where the sinuses of Valsalva join the tubular ascending aorta, which is the next section. And then the top where we have the branches going off to the head and neck and to the arms, the upper body, is the aortic arch. And then we have the descending thoracic aorta, which goes from the arch down to the diaphragm. Once it passes through the diaphragm, we're now in the abdominal aorta. Nancy, go ahead.
Is it possible to scan all the way up to the arch in hyplax?
Sort of. It depends on how much lung interference there is. It's going to be difficult. But yes, you can. You can see the ascending. So if you come in suprasternal notch, you can often see the arch pretty well. You can also come right suprasternal, and you can kind of see it from that perspective. Your right parasternal, or right parasternal, a little bit higher up window, you can see the ascending portion as well. That'll help you to see it, but you're going to have to kind of piece it together. You're not going to have one view that really sees it well altogether. Sort of can see it from the jugular notch. You can see down, so because you can actually see down to the left atria there if you have enough depth, and you're seeing a good enough window, but that's going to be more difficult. That's with transthoracic.
Okay, cool, thanks.
Yeah, transthoracic is going to be a little bit more difficult. Obviously, the descending, we can see it a little bit beyond the heart, like in a 2-chamber view or the parasternal long axis. But we're not going to see the full descending unless you're doing a transesophageal, which runs right alongside it in the esophagus. So with transesophageal, we'll get a much better view of it overall. But we'll get the snippets that we can as we can get them. Okay, and then in the abdominal aorta, just for review for vascular stuff, if you're doing vascular exams, you actually have, we consider it proximal, mid, and distal. I kind of go from the celiac SMA origin up to the diaphragm is proximal. Below that, down to about the IMA is mid, and then from the IMA distal, even sometimes including the IMA, is your distal portion, and then it bifurcates into the iliac. Okay, so transesophageal is as good as CT and MRI. We're usually the stepchild that is neglected and in most of our imaging stuff compared to CT and MRI. But this is one area that we are very close to, and we are much more cost effective and faster at performing it. Well, CT is pretty darn fast, so I won't say that. And it's effective without having to move the patient and go through those uncomfortable procedures and stuff like that. And they don't have to take dyes and various things to be able to see it. Yeah, Nancy?
Sorry, is the slide says TEE?
Yes.
Is so that's where you're saying we're good and but faster? Oh,
yes.
Okay, sorry, I got confused.
Yeah, no, so we're saying we're as good because we get great detail resolution, particularly with the descending thoracic aorta, because we are literally right beside it. And in fact, when we're scanning the heart, I don't have a transducer with me in the room, but as you twist your entire transesophageal probe, you're going to go from seeing the heart, you're going to twist it around, and you're going to see the aorta, because we're going to be directing the beam towards the back. Off of the heart and onto the aorta. And that's usually the last view that the doctors will do as they do their TEE exam, is that they turn it to the aorta and they pull it out and they take a video clip of it all the way up the descending thoracic aorta to look for plaque and dissections and various things like that. That's usually the last view of a TEE protocol. Different diseases affect different portions of the aorta. So we'll talk about those. And we've already talked a little bit about disease processes in the aorta abdominally. Same kind of stuff. It just is a little bit more critical as it gets closer to the heart. So atherosclerosis. So we're going to look at plaque buildup. We could have aneurysms, thrombolytic type of disease in there, or thromboembolic disease in there. We could have dissections, as we've mentioned. As I throw the term out, thromboembolic, what does that mean to you?
Bad.
Not thromboembolic, but atheroembolic.
Propagating clot.
Okay, so blood clot that's breaking off, because as it embolizes, it's going to go downstream. So if it's in the descending thoracic aorta, where do you think that might go? Is it going to cause a stroke? It should not cause stroke because it's going to be beyond the head neck vessels. It's going to go downstream, but it could block off things like your liver, your kidneys, your spleen, your legs. It's most likely to hit legs and stuff because that's sort of where the natural tubular shape goes. The other ones have like a 90-degree takeoff of that, so that kind of protects those organs a little bit. If that atherosclerotic section that was embolic is up in the ascending aorta, then it is likely, or a lot more likely, to cause a stroke. So it could go up into the carotids and go to the brain. Neoatherosclerosis. So these are things like cystic medial necrosis. So that's like cystic medial necrosis is sort of like Marfan's type of syndrome, where it's that connective tissue type of disorder that weakens the walls. With that, we would get aneurysms. There could be dissections again, intraluminal or intramural hematomas, annuloaortic ectasia, which is just a stretching of the annulus of the aortic valve. We have inflammatory type of processes that affect the thoracic aorta. So we have Takayasu's arteritis, we have giant cell arteritis, and endocarditis, which again is endocardial lining spreads and propagates through the whole system, not just the heart, but it goes into the vasculature also. Then we have our congenital types of abnormalities like Marfan's. We have Turner syndrome, Ehlers-Danlos syndrome, other familial aneurysms, bicuspid aortic valves, aortic coarctation, etc. And then the last thing that we'll talk about will be things like trauma and intraluminal thrombus, hypertension, aortic insufficiency and stenosis, and then iatrogenic injury. I can't talk this morning. All right. So 6 segments of the thoracic aorta. So just to review again, like that picture was, and we'll have more pictures again. We have the annulus. So it starts with the annulus of the aortic valve, which is what the aortic valve is attached to. We have the sinuses of Valsalva, so we're used to measuring those, which is our aortic root. We have the sinotubular junction, where the root joins the ascending aorta. And then we have the tubular aorta, which, as suggested, it should just be a cylindrical shape going up. We have the arch, and we have the descending thoracic. So those are the 6 segments that you will need to know. Aortic root is part of the fibroskeleton of the heart and is resistant to dilation. So it doesn't mean it can't dilate, but because it's fibrous, it is a lot less likely to dilate. So if it does dilate, it's a significant amount of pressure buildup causing that to occur. The aortic size is relative to the body surface area of the patient and their height. So again, if we're talking about somebody who's 4'10" versus somebody who's 6'7", there would be a proportional difference. So of the sinuses of Valsalva, they should be 3 equally sized. So when we're looking at it in peristernal short axis view, we should note that they have relatively the same size. So it's not a round structure, it's kind of almost cloverleaf shape, 3-leaf cloverleaf shape, but they're symmetrical and similar in size. If one of those is significantly different, that should give us a clue that there's something not right. There could be a congenital abnormality, there could be something else going on. Right and left contain the ostia for the respective coronary arteries, so we look for those to be coming off. In some labs, you'll actually be trying to document where they actually connect. And speaking to Tammy from a pediatrics standpoint, she said that the connections when they are when they're normal or when they're abnormal, they tend to be a little bit easier to see. When they're normal, particularly off the left, they tend to be hard to see because that's like a 90-degree perspective to our color Doppler. So they can actually be harder to see in a normal situation as opposed to an abnormal situation. The right is technically more superior in the body compared to the left, and it's closer to the sinotubular junction, which is more superior. Okay, so I do want you to know diameters. So this is a diagram showing us the diameters. The annulus should be roughly 20 to 31 millimeters. So that's 2 to 3.1 centimeters. Sinuses of Valsalva, so this is the aortic root diameter, should be between 29 and 45. That's a pretty decent size difference range for normal. Sinotubular junction, so where those sinuses of Valsalva come down and join the tubular aorta, that should be 22 to 36 millimeters or 2.2 centimeters to 3.6. So these are decent sizes. Putting that in perspective, 36 is like your average left atria when it's full. Okay, so that's a decent size. So they should be similar in size. 22 to 36 for the ascending, just like the sinotubular junction. So again, it's cylindrically shaped all the way up. Same with the aortic arch and the descending thoracic aorta. Okay, just as a side note, so 36 millimeters is still considered normal, okay, in an ascending or thoracic aorta. What is considered aneurysmal for an abdominal aorta?
Over 3.
over 3. So
Or
this is above 3. So don't get super excited because it's over 3, because in the thoracic aorta, we start with a larger tube and it gradually tapers down through the abdominal aorta and down to the legs. So that taper at the diaphragm should be less than 3. If it's 3, it's aneurysmal. Here, 3 is normal. 3.6 is normal. So just wanted to make sure that you don't confuse that with and start over calling these insides. Nancy, go ahead.
In our edition of the textbook, it has the descending aorta as 20 to 30 millimeters instead of 22 to 36. Which one? I'm sorry, what?
Is that descending thoracic or descending abdominal?
Descending thoracic.
Okay.
I'll show you the picture.
So yeah, so at the arch, it's up to 36.
Whoops.
They have a natural taper down to less than 3 centimeters at the diaphragm. What page are you on?
Yeah, on page 612, it's right there. So I just wondered for your exam, which numbers are you gonna use?
It will be consistent with the current text. 612. Yeah, so they just didn't have it in there, but it is, you know, anything less than 3 at the, anything 3 and over in the abdominal is big. So that natural taper continues with that. So yeah, for my testing purposes, I would say 20 to 30 at the descending thoracic. So we often worry about aneurysms and things getting too big, which is obviously concerning. I think I jumped ahead here by accident. But note that there's a small size as well. What do you think it means if a vessel is smaller than normal? So say it's smaller than 20 millimeters or 2 centimeters. What do you think that might mean?
Coarctation?
Okay.
inflammation.
Yeah, particularly in descending thoracic aorta, coarctation is a big concern. So coarctation happens. So the ductus arteriosus is a connection between your pulmonary artery. So where your pulmonary artery branches out to left and right, I believe it's usually on the right branch that it comes and it joins into the abdominal aorta, which sits transversely to the pulmonary artery. So there would be a connection right. Let me get my laser pointer out. There would be a connection right here. So when we see a patent ductus arteriosus, this is where the connection is. After birth, before birth, that's supposed to be open. After birth, that's supposed to close off shortly after birth, and it becomes like a ligament. It becomes just something that holds and tethers things together. However, as anything that's vascular in nature, if you put enough pressure behind it, it will actually reopen. So I talked about us being able to recanalize an umbilical vein with the same concept here. If the pressure is high enough, it will cause that to reopen, and then we'll have an open PDA, which in an adult is not a normal thing. But if I get a coarctation that occurs here, most coarctations happen around this area. They can happen technically anywhere, but this is one area that's most likely to happen. If somebody grows to be an adult and they never had that corrected from when they were a child, that stenosis essentially caused a restriction of blood flow, and we have an abnormal development of everything below that level. So if you're looking at a patient, and I was actually laughed at in the lab that I worked in Colorado Springs, because one of my colleagues had somebody that had a descending thoracic aorta, because they're not thoracic aorta, they're actually scanning the abdominal aorta. Their abdominal aorta was like 17 millimeters. I'm like, that's small. It might have even been smaller than that. I think it was like less than 1 centimeter, actually. It was significantly small. And so I asked them, like, so does that patient have like a disproportionate upper body to lower body? And she's like, yeah, they're kind of, you know, they did have that. So they're everything below the chest was basically smaller than proportionally than everything above the chest, from the chest up, because it wasn't getting perfused as they developed from a baby to an adult. And I got laughed at because I'm like, yeah, they probably have a coarctation. And they're like, oh, that's silly. And they got laughed at. And then the doctor, when they came to interpret it, that's the first question they asked is you know, that it's probably coarctation. So whether you get laughed at or not, the physiology does make sense that if you don't get the perfusion, things don't grow the way they should during developmental process. So we're not only looking for things that are aneurysmal, which is more common in an adult, but we're also looking for things that are underformed and smaller than they should be. Okay, so just keep that in mind with any vasculature. Okay, and that's the difference between getting a stenosis when you're an adult and acquiring that stenosis. Then you get problems because the demand isn't the same. The problem is if that happens during growth process, you're going to underdevelop those structures. Okay, and so looking at it from this side perspective, just to note, so if we're measuring LVOT, LVOT is going to be just on this side of the valve. So there's your annulus there in the black. Okay, so it's just going to be on the LVOT side of the valve. If you're measuring the annulus itself, you can measure on the annulus to the annulus, which is going to be slightly more narrow than the LVOT. Then our leading edge to leading edge is going to be the width, the maximum width of your sinuses of Valsalva area. Okay, and then we will often measure the sinotubular junction, which will also be leading edge to leading edge. And then according to ASC, we're going to measure the ascending as leading edge to leading edge on the ascending aorta. And so we're going to stick all those measurements on there. I believe Tyler has you measuring all of those on your labs. Is that correct?
Except for the sinotubular junction.
Oh, he doesn't have you measuring that?
No, but Tammy said you should be measuring it on every exam, especially if there is a membrane, a subvalvular membrane.
Right. Yes. And the reason we do that is because after a stenosis, our sinuses of Valsalva will dilate, and that dilation is going to cause that sinotubular junction to not come down as it should. So that is an area of interest, particularly for pediatrics, but it's an easy measurement to take, and so I would do that also.
Yeah, because it's probably also at end diastole, like the root would be, correct?
Yes. Now in pediatrics,
Yeah.
the ascending aorta itself, not the sinotubular junction, but the ascending aorta will be measured in systole for pediatrics.
Tammy said anything on the downstream side of the valve is end diastole, leading edge to leading edge.
Okay. We'll go with that. She's the expert. Okay, so as you can see here, so Nancy, your question earlier was, can you see the aorta, through the ascending portion? And here's a good example of, yes, you can. It's not always going to be seen. What we have to be careful of when we're imaging is not to have this depth too shallow, because we will miss it if it's too shallow for sure. There, see the arch decently here. This has a lot of artifact and stuff in it. We can see the 3 head and neck vessels coming off. Aortic valve would be here. Here's your pulmonary artery, just to review anatomy. Behind that in this area should be the left atrium. Okay, so you should be able to see that if we can get a decent enough window. People who are big chested people are going to be harder to see that, and the more lungy they are, the harder it is to see also. Yeah, go ahead.
In plaques, if you were to see it after the ST junction there on the left where the measurement is, and you were to go up and you would see the arch if you could, which way would it go?
It's going to come up
left, right, down?
That way.
Okay, thank you.
It's going to arch over. Typically, we're not going to see it that far from peristernal view. Right peristernal, maybe. Not from left peristernal, because it goes behind the sternum. And then the descending. The hard part about the descending is we often see it about to here, which is good because this is where your PDA would be. You can see that the pulmonary artery isn't necessarily right touching the wall. The PDA is actually a bit of a tube that goes between it. So you can see those kind of trailing in between. But this area is important to see. When we stick color Doppler on, we're going to be particularly focused on this area because that's where coarctations are likely to occur. Again, they can happen anywhere, but that's most likely where it's going to happen. Beyond that, you can see that transthoracic, we tend to lose the descending thoracic aorta pretty quickly. In fact, it actually goes off this direction usually, and not necessarily straight up and down. So we tend to lose it. We are going to rely more on the color Doppler than we are in 2D here because of the artifact that we tend to get. You could measure distances here. We could also take it in short axis. So we're seeing the arch right now in long axis. If we turn 90 degrees to that, we would see a tube on the top, and then you might lengthen out your pulmonary artery on the bottom because they're 90 degrees to each other.
I have a question.
Yeah, go ahead, Kelsey.
From that image there, can you show me exactly where two different structures would be? One being the ductus arteriosus if it were not to close, and the ligamentum thingy.
Ligamentum arteriosum.
Yeah, that one.
Because there's two ligaments. There's ligamentum venosum, which is actually on the liver side, and the ligamentum arteriosum is this one, which becomes the PDA. That is the PDA. If it's
Okay.
open, it's the PDA. If it's closed, it's the ligamentum arteriosum.
Okay,
Which-
right.
From here to here. Okay, so it's on the descending thoracic aorta side, just after the head and neck vessels. That's where it tends to connect. Does that answer your question?
Yeah, it does. Thank you.
So we often show this in long axis, but remember, if you are looking at something that's aneurysmal, you want to also go 90 degrees to it, and you want to show it in short axis, showing the round aorta. Now, you're only really going to see the top of the arch with that, and what you have to be careful of from an AP dimension well, it's actually from the top to the bottom on your image, is that we're not including the carotid arteries and the subclavian and stuff like that, because they will tend to make it look larger than it really is. But we are looking at transverse measurement across to see how wide that is. Okay, so geometry is important, and like Kelsey suggested earlier, that if we have one of those bands of tissue or something, a subaortic stenosis or some other congenital stuff going on, but it could also be a significant, like a severe aortic stenosis, can cause the sinuses of Valsalva to dilate, but it can also cause, if that dilation extends out into the sinotubular junction and into the ascending aorta, that geometry is not normal, and we have to recognize that when it doesn't come back down and taper to a normal size. Because after the high velocities, we get into the turbulence. That turbulent area causes high pressure. That high pressure is what stretches out so we have a post-stenotic dilation, basically, is what's happening, just like in an arterial system. All right, so that sinotubular junction is crucial to normal coaptation of the aortic valve. If it gets stretched out significantly, it's going to affect how the aortic valve closes. Okay, so we've already defined the portion. So ascending is from the sinotubular junction to the brachiocephalic artery, the first of the head neck vessels. The arch goes from that to just after the left subclavian and the ligamentum arteriosum. So the ligamentum arteriosum is kind of the anatomical divider. And then beyond that is descending thoracic aorta. The note is the arch is often seen by transthoracic in that suprasternal notch, and we know that that's a pretty uncomfortable view, but that's the view that we need to obtain it from. Okay, so do not confuse the descending with the coronary sinus. So we've pointed out several times in parasternal long axis view, seeing where that. So what is the anatomic area of the heart in that perspective that we're seeing a coronary sinus? What's that groove called?
It's the atrioventricular junction, the posterior sulcus.
So anatomically, yeah, the atrioventricular groove or sulcus, which is that grooved area. So that's where we're going to see it. Remember, the descending thoracic aorta sits a little bit superior to that. It's going to be more dilated and thicker walled. Okay. We should usually see the coronary sinus expanding and collapsing as the heart contracts. The aorta should pretty much stay the same. It's going to pulsate somewhat, but not change significantly in size. TEE is obviously much better at imaging the entire thoracic aorta, as we've already suggested, because we're right adjacent to it. This is not an image from that. This is actually from IVUS. So this is an intravascular type of catheter that goes in as imaging from the inside out. This is used to look at plaque burden. It's used to look at thrombus formation. It might be used for looking at dissections and doing procedures and stuff like that. Natural aging process. The vessels tend to become more tortuous as we get older. So just like in a carotid artery or an abdominal aorta, the thoracic aorta is the same. The older the patient gets, the more likely it is to become tortuous. Now, in an abdominal aorta, it tends to go towards the patient's left side. So if it kind of arches over, it doesn't go straight down by the spine. It will bend toward the left kidney. I don't know that that's true or not in the thoracic. Just know that if it becomes significantly tortuous and bendy, that's a normal aging process. So IVUS is that top picture that we're seeing there. That's that intravascular ultrasound. So it uses between around 20 to 30 megahertz transducer. And it images again from the inside out. It can be used also to help create fenestrations, therapeutic fenestrations for dissection. So what is a fenestration? Yeah, it's us poking holes in it. Okay, so if I've got that dissection, it usually has an intimal flap. Some of them can be pretty thick, but if it's causing a blockage of flow, or if the pressure behind the false lumen is too great, it will start to occlude the true lumen, and it becomes problematic, obviously. So sometimes they'll actually poke holes through that so that there's more of a flow between that, so that pressure doesn't cause obstruction of flow. And they might use that for that purpose. Intracardiac transducer, or ICE, is a 5.5 to 10 megahertz probe. So that's going to be similar to like the TEE megahertz wise. So it's a higher megahertz than what we use on our transthoracic, around usually a little bit higher than a TEE probe would be. With higher frequencies, we can see that intimal and medial layers much better. And because we're right adjacent to it, it's going to be obviously seen with better detail resolution. So MRI and CT are better at detailed 3D reconstruction. In fact, on the PET scans and stuff that we talked about yesterday in the image analysis class, those can look pretty dang awesome, actually. Those reconstructions can look super, super cool. But they are quite good at those 3D reconstructions. Again, just showing the differences in transducers. So our transthoracic, this is a TEE. So this, you've seen that, it's pretty hefty cord. It's a gastroscope type of cord. Remember that the end and stuff is flexible. It flexes both anteriorly, posteriorly, but also side to side. And that's controlled by those rotary controls here. The crystals on the end of it here are controlled by these little buttons, which can digitally spin or turn or sweep the crystals. And that's basically changing the phasing of the probe to do that. The other thing to note on these gastroscope type things, you'll notice that it's got centimeter markers all along it, so they know how far down to push it into the throat roughly, and then manipulate it from there. So similarly, the ICE transducer is much thinner. This obviously goes into the arteries. So in the cath lab, they stick it directly in. It's in the artery and goes through, and it goes up into the heart, and then it's imaging the heart from inside out. Okay. It does have more like a sector. So this image at the bottom, you can kind of see this is up inside there, and it's looking into the left atria in this case, and the atrial septal wall. You can bend it and stuff just like they do the TEE. Instead of these rotary controls, these ones have it kind of along the collar of that mechanism. And then this cord goes back and actually plugs into an adapter, which plugs into your ultrasound system. So that is what an ICE transducer is like. And IVUS would be typically a little bit smaller than that, but looks similar. All right, so dilation and aneurysm, that's mostly what we're looking at and concerned about with the thoracic aorta. So any point, we should have a prompt evaluation of the entire aorta if you're noticing these to occur. and they can occur at any point along the aorta. So aneurysms are considered anything that is more than 1.5 times the normal dimension. Okay, so there's a 50% more increase in size from the normal section to the abnormal section. So just like an artery in the regular vasculature, if even if it doesn't become aneurysmal, if it increases more than 50% without getting over 3, that's an indication that we have an aneurysmal segment. If it gets more than 50% size compared to an adjacent section that's like a centimeter or so away, that's an abnormal increase. It should normally be tapering down gradually all the way down. So even if it doesn't hit aneurysmal stage, you should still note that increase and show it with documentation and measurements. Bicuspid aortic valve is often associated with concurrent primary diseases of the aorta. So if you see a bicuspid aortic valve, we definitely want to be looking for aorta issues. So let's take Marfan syndrome, for example. So when somebody has bicuspid, they could have Marfan's. It could be independent and just on its own. But why would we look at the entire aorta with Marfan syndrome if we note that it's got a bicuspid aortic valve? What's the disease? What's the problem with Marfan's? What's the fundamental?
They're gonna blow. They're big. They have a big dilation anyway.
Yeah, so it's because it's a connective tissue disorder, and our blood vessels are made up of connective tissue. And so as that becomes weakened, it tends to stretch much faster. So we definitely want to be looking at the entire aorta if you notice that a patient has a bicuspid aortic valve. They may not even know they have Marfan's or anything like that. All right, annulo-aortic ectasia. So again, the annulus of the aortic valve becomes ectatic. Ectatic means that it's stretched out, it's dilated, but it may not be like aneurysmal. That could be idiopathic dilation, but it could be caused from one of these other processes. Primary aortic dilation might be caused by something like cystic medial necrosis, like Marfan's. So again, that's a connective tissue issue. It's those middle layers of the vasculature that are weak. Cystic medial necrosis may also be secondary feature. So just remember the difference between primary and secondary. Primary is that is the disease process that caused it, whereas a secondary, it may have become that way because of something else that's pathologic. Okay, and then Marfan's again involves the ascending aorta and the sinuses of Valsalva typically. So we'll notice it right close to the heart. Secondary dilation could occur because of that pressure and volume overload inside. And then that post-stenotic dilation, as I mentioned, may take away that difference between the sinotubular junction and the aortic root. In this case, the annulus might be more stable. Aneurysms past the sinotubular junction are best seen with transesophageal because we, again, don't see beyond that super well, except from our suprasternal notch perspective. And as you can see here with this PET scan, you can see how beautifully they can see that whole aorta with the branches. You can see the coronary arteries taking off. You can see where the aortic valve is. And they basically eliminated all the other stuff around it. They do what's called a subtraction technique where they remove the other data that's irrelevant to this. And then this is what they call a 3D reconstruction, and they can actually kind of spin it around. So you can see here where it looks like there's a bit of a kink or a fold right there in that aortic arch or just past the arch. They could spin that around and see if that's just the perspective they're seeing or if that's truly open. They would see that pretty well in CT. So likely if we do see something and we're not doing a TEE, they're likely going to get a CT is probably the imaging of choice to be able to look at these dissections because CT is very quick. Even if they have to use contrast, it's going to be a very quick exam relative to an MRI. Obviously, if there's concerns of dye and interaction that way, they're going to probably use an MRI instead. All right, so here's an example, and this is, yes, I got pet peeves. And that's partly because I'm a vascular tech as well. So from a vascular tech perspective, we always measure outer to outer because we don't want to miss what's going on. So the pitfall is that if we're measuring the lumen, which is marked in L here, and this should be a little bit darker, we would typically measure what we call leading edge to leading edge, okay? But if we did that, we're only measuring the lumen, when in fact the entire wall of the aorta is all of this here. So we have to be perceptive enough to note that this is all part of the aorta. We have to measure the entire thing and not just the lumen that we see, because this thrombus can blend in very well with the surrounding tissue. Okay, so our pitfall is that we're going to miss where the walls are. And I guess that's my pet peeve as a vascular tech, because we're very careful to not miss the outer walls. Kelsey?
So I'm just, is this like a short axis, like short view, or
Yes.
like short axis suprasternal? Okay.
Yes, so this is a 4V1 C transducer. That's a cardiac transthoracic. So this is likely short axis in the jugular notch. Yeah, so we're pretty close to it. We're not on the head neck vessels, which is good, but we're seeing it just before that. But what to note is that this is the actual adventitial layer right here. And we have to be perceptive enough to catch that, because we can miss a significant aneurysm if we assume that this is just the aorta here where the L is.
And so like, where is this, like before, is this the ascending, the arch? Like I'm trying to get my landmarks here and I can't really tell.
Yeah, so it's likely right close to the arch, because that's going to be closest to it. Is it before, in between, or after the head neck vessels? We don't really know unless you're scanning live. It's probably just before the head neck vessels branch off is my guess, but that's just a guess.
It looks to me like it would have the involvement of like your head and neck vessels.
Yeah, it could. So, obviously we'd have to be careful of that. If this is a big thrombus there, this is a huge stroke risk, obviously. And we know that this is not transesophageal because of the transducer selection that they have here, and we don't have those sectors and stuff like that. But this is in fact a regular transthoracic echo. But that's the only place we're going to see it that well. Even in abdominal aorta, you're not going to see that well unless that patient is super, super thin, because we are less than a centimeter and a half from the skin surface. That's a good size one. So measuring wise, if we're looking at these as centimeter indicators, I've got about 1, 2, 3, 4, 5, 6, 7, 8, 9, maybe 10 centimeters. That is huge. That sucker's ready to pop. And just because it's thrombosed inside does not decrease the chances of rupture. The size is going to have a big chance of rupture alone. But just because it clots up doesn't decrease the chances of rupturing. It's still very high. That's why they have to do these procedures to fix it. Okay, so the degree of dilation is directly linked to the likelihood of dissection. So as I just mentioned, the bigger it gets, the more likely it is to rupture and or dissect. 55 millimeters of dilation requires surgery. So 5.5 centimeters. Okay, the one we just looked at was at least about 9 transversely. In a good lab that does a lot of these, they can have pretty good outcomes doing these procedures at 50 millimeters or less. So they can do pretty well. Obviously, we don't want to go and do open heart or transthoracic surgery unless we have to. Abdominal surgery would be much easier to do than transthoracic. Changes of 5 millimeters per year would also indicate surgery. So when somebody is aneurysmal, we're not going to jump to necessarily doing surgery until it hits a certain level. In this case, 55 millimeters is indication of that. But if it's smaller than that, so say if we're 4 to 4.5 centimeters, it may not qualify for surgical intervention unless you have a change of 5 millimeters over a year's period. That's a rapid change in our world. Okay, and it usually coexists with substantial atherosclerosis, and there's usually quite a bit of plaquing that goes on with this. And if that's the case, it's likely to dissect if it's got those plaques in there. All right, so back to Marfan syndrome. So again, it's a connective tissue disorder affecting the ascending aorta and that bicuspid aortic valve. Sinuses are disproportionately involved. So remember when we said in short axis, the sinuses typically have kind of a clover leaf shape, and each of them are approximately the same size as the others. So in Marfan's, they might be different sizes. Once identified with aneurysm, we should also evaluate for mitral valve prolapse, because that's also something that they tend to have. Just as a review, what was mitral valve prolapse?
Just like the backwards motion of the leaflet into the LA past a certain point.
Yeah, past your, so the reference is always your annular plane. So my elbows will be the annulus, okay? It's supposed to coap like this, come down to about there, but if it slips down past that annular plane, then it tends to reopen a little bit, and it's flail when that tip goes the other way, but otherwise it's prolapse when it just slips down. So we're gonna be looking for that. TTE should be used as a screening tool for first-degree family members. So if we do find somebody with clues of Marfan syndrome, we're going to go scan their first-degree family members. So again, what's a first-degree family member?
Brother, sister, mother, father.
Yep, so direct close relatives, yes. Let's see. Once they establish Marfan syndrome on that patient, then they are probably going to do a CT or an MRI to evaluate not just the entire aorta, but other structures in the body as well, because they tend to, when you have aneurysms in one place, you'll tend to have them anywhere, because it is a connective tissue disorder. Another area that's concerned to us is up in the brain. We don't want those rupturing, causing hemorrhagic strokes. And then beyond that, they may use echo to do routine evaluation follow-ups. So we'll do that routinely for progression of disease. We may do that over 6 months, depending how concerned they are about it, or it might be like every year or so. So remember, again, if it changes 5 millimeters in a year, that's bad. Okay, so with the sinuses of Valsalva, aneurysm most often involves the right, the non-coronary, or the right coronary cusp area. And the overall length of a sinus of Valsalva aneurysm is about 3 to 5 centimeters. So that's pretty long. Right side often produces what's called a windsock type of an appearance. So like the picture down here. So this is a windsock. So if you drive by an airport, or you go to even like the helipads and stuff by the hospitals, they always have these windsocks. So it's open on both ends. The wind goes in and it basically points the direction that wind is going, so that pilots know how to kind of land a helicopter or planes or whatever they're flying. So here's an echo appearance of that. So we have our this is transesophageal. So this is non-coronary cusp, left coronary cusp. And you can see this big long appearance of that cusp. Okay, that's a windsock appearance that you can see on that picture. So if you see that, that ain't good. That's not normal. Okay. So from peristernal short axis might appear as a mobile circular structure mimicking a cystic type of mass. It can detect inferiorly to into the IVS appearing as a cystic structure, and it can also protrude in towards the left atria. Yeah, go ahead, Kelsey.
I guess I'm just confused a little. So we get the windsock appearance.
Yep.
From a Marfan syndrome aneurysm, or just, I just
Yeah,
don't
it
know
could
why
be-
it's only that cusp.
It could be, it can happen on Marfan's because it is, again, a connective tissue disorder. I don't think it's exclusive to Marfan's. It's just because of the connective tissue issues, it's stretched out and becomes that way. But Marfan's is one of those things you're going to look for sure if they have Marfan's. Nancy?
Just to help with your transition, Kelsey, in the book, Marfan's was a header and it went through a section. And then sinus of Valsalva is another section now. So we're not in, it's just Marfan's now, we're into just sinus of Valsalva.
Next header. Yep.
Thank you.
Good point. Okay, so the fibrosa aneurysm, these are exceptionally rare, forms in the skeleton and communicates with a Valsalva sinus via relatively narrow neck. So first of all, when I say skeleton, what are you thinking of? It's the fibrous skeleton of the heart itself, not our bones, right? Okay, so it's going to communicate again with the sinus of Valsalva and have a relatively narrow neck. I don't know if I have any pictures of that. Or is that in there? Okay, yeah, so this is seen as a cystic space between the aorta and left atria. This is what we're showing here. So you can see that this is parasternal long axis view here and here. This one's a little bit more echogenic, maybe a bit more calcified, but it's this little outpouching. There's aortic valve annulus right there. Okay, again, right here, this is one that's in here. They don't see the aortic valve super well, but you got this cystic type structure poking into the left atrial space. Basically.
Why that looks I feel like that's an abscess, or it looks like one.
It could be, but what would be the difference, do you think, if you're looking at this versus an abscess?
Like the patient features.
Okay, so it's probably going to come back to patient history. Did they have an infection previously? This may happen independent of an infection, but you know, it just being the devil's advocate, if they had an abscess years ago and they had this formation occur and it opened up, okay, which we know they can do, then it's also going to have that same appearance. So I'm sure they would do other testing and stuff to prove what it is, but that's basically a cyst in that it's a fibrosal aneurysm anyway in that fibrous skeleton area.
So okay, so an aneurysm, is that gonna look the same as the cyst with color on?
Yeah, it's probably going to have flow in it because it's an aneurysmal portion of that skeleton. So it looks like there is a connection occurring between it. So if I stick color on, I should see flow going into it and maybe out of it. So our job is basically going to show that it's there. We're going to measure it in 3 dimensions. We're going to prove if it has a connection like this picture shows here and with color Doppler. And we'll show how it is related to other structures like the aortic valve annulus, the mitral valve annulus and stuff like that. We'll try to show it as many perspectives as we can and get some measurements of it. That's about all we can do. And so I would hate to do an exam and not really know what it is and be like, I just didn't see stuff very well and pass it off as nothing. And the doctor never saw those pictures. It's always appropriate to show it to the doctor and then they get to make the decision what they think it is and or test further to see what they determine it really is.
So again, it's just
sorry.
So again, it's just in the report, we're just describing echo features. We're not like suggesting anything.
Yeah, so when it comes to masses and weird things, measure it, show connections to stuff, and give an exact location as to where it's attached or if it's just free floating around. Yeah, that's important. Yeah, CT and MRI is what they'll use if we can't determine exactly on echo. All right, so next section, dissections. So we know that dissection is what?
The tearing off of a vessel wall layer.
Yeah, so it's the intimal layer, part of the medial layer typically. Blood flow typically gets in behind it. If we're talking about a lot of vasculature out beyond the heart, we are usually talking about a to-fro flow. So meaning that flow goes in and then it comes out during the cardiac cycle. It's usually opposite that of the regular flow. However, up near the heart and in the thoracic aorta, we can get the flow going the same direction, and the only real marker there for us is to see the actual intimal flap, because it can go the same direction as the heart as it's normally pumping. So dissections have an annual incidence of about 10 to 30 per million. So that sounds like a small number, but in the medical world, that's actually a fairly high number, percentage-wise. That's a pretty decent number of people that will see it. It presents as a sudden onset of severe chest and or back pain and has a wide range of other presentations. So like tamponade, this is something I would suggest is a medical emergency. And the closer to the heart it is, the more emergent it becomes. So it's not that they can't survive, it's just that the likelihood of something rupturing goes up significantly once they start to dissect. Okay, and it is going to be quite painful. If it's in the thoracic or abdominal aorta, it tends to radiate towards the back. So the patients along their spine, they'll have quite a significant pain. And again, it's sudden onset. Again, if aorta ruptures, they could have as little as about 15 minutes to live. It can be very quick. All right, so acute aortic syndrome is aortic dissection, intraluminal or intramural hematoma, and which means that it's a blood, like a, it's a bruise. It's a big bruise essentially around it, and that blood starts to coagulate. Atherosclerotic plaque rupture and aneurysm rupture all have similar clinical presentations. So any of these situations, the dissection, the hematoma, the plaque rupture and aneurysm rupture, they all present the same way with that acute severe chest and or back pain. Typically presents in dilation, in the presence of dilation with Marfan syndrome or severe, usually severe hypertension. 50 millimeter of dilation defines the risk factor. So once the aorta exceeds 50 millimeters, then we are much higher risk of dissecting. And roughly 40% occur with smaller diameters. So it's not that it can't occur at smaller diameters, but 50 is sort of a marker to say once it hits us, it's a lot more likely. Yeah, Nancy?
Just to note, the book says that currently it's felt that aortic dilation of more than 55 is the definite risk factor for dissection, although the 40% was smaller. So is that because people are getting bigger?
I don't know. That's a change from the last version to this version. So I'm going to stick with 50 millimeters for my testing purposes. They've just changed the threshold a little bit. Obviously, they're more comfortable with raising that without missing a significant number of patients. Okay, so there's two variants with dissection. So one is the classic dissection, which is a tear starting either at the ascending aorta and it propagates distally, so towards the legs, or at the ligamentum arteriosum, which then ascends backwards towards the arch. That may present with a limited intimal tear without dissection and be very subtle. And then the second one is spontaneous intramural hematoma, which is about 5 to 10% of cases. So in other words, the classic is that there's actually a hole and it tears away and it gets blood in between those layers that then tears along. The other one is getting a bleed in between the wall that is what causes the rupture to occur, but the intima itself is actually intact and it doesn't create a lumen behind it. It's just collecting it's basically a bleed into the wall that's tearing along the intimal layer. It's just, but the intima is still intact. Hematoma propagates without rupturing again into the lumen. Classification, we're going to go the Stanford or DeBakey classification, which we'll get to in a moment here. First, we'll just show the two. So this is the one showing that there's a connection between the intima. The intima is actually torn and there's a space where the blood is actually able to get in and behind it. Whereas the hematoma, as you can see from both the transverse and longitudinal, the intimal layer is completely intact. It's just bleeding inside the wall, which is, and that pressure as it increases tends to tear along that vessel. Now it can tear lengthwise, but it can also tear circumferentially as well. So if you look in transverse, it can tear around the edges. And here's our chart with the Stanford A there's a Stanford and DeBakey type. So Stanford is basically everything that involves ascending aorta is going to be a Stanford A classification. I'm going to hit Stanford first. Stanford B is anything basically from the ductus arteriosus area and below. They could have isolated arch dissections as well. These may involve the head and neck vessels, and that's obviously problematic. Now the DeBakey classifies it a little bit further. So DeBakey 1 is above and below. And a DeBakey 2 is just the ascending. And DeBakey 3 is just the descending. So just a slight difference there. And it depends on the lab and what they use to diagnose that. Yep, so they got the same stuff there. Okay, so know those for testing the different types of classifications. Our descending aorta involvement. These are the ones that we're concerned about because the closer again to the heart we get, the worse the outcomes could potentially be, and very quickly. Because if it continues to tear, if it goes up the ascending aorta, where do you think it's going to eventually hit?
The valve.
Okay, yeah, it's going to hit the aortic valve, which then causes bigger problems, right? It could, we talked about tearing into the pericardial effusion. So if we tore and started to rupture up at that area, we might go into tamponade by creating pericardial effusions. So those things, they can be very, very dangerous. They may be lethal and have a great likelihood of subsequent rupture, pericardial effusion, aortic insufficiency, and coronary involvement as well. So that could send them into a heart attack. So these are all very emergent stuff. So if you see a dissection, again, this is not something you want to necessarily do a complete 1 hour echo on. This is something you want to flag your doctor as soon as you can. And again, don't be panicked by it, but let them know right away what's going on so they can plan to do a procedure and fix that. Because that patient could go downhill very quick. Doesn't mean they will, but we don't want to take the risk. Surgical emergency, transesophageal can play an important role there. They may actually scan it while they're doing the surgery. Type B of the DeBakey 3 is managed medically unless it's complicated, unless it complicates. So again, DeBakey 3 or type B, Stanford type B is descending thoracic aorta only. So that one, it's important to note it because we still stand a good chance of rupture. We want to have that taken care of as soon as we can, but it's not as emergent as once it hits the head neck vessels and beyond into the ascending. This is just a, I believe this is a CAT scan. You can see the actual intimal flap on these. Okay, so you can see that flap. This is the false lumen tends to be larger than the true lumen. So this is typically the false lumen that you're seeing here, and this would be the true lumen, the residual actual flow in there. And you're looking at these weird oblong shapes of the aorta. This is this is on the arch. So it's just how we're intersecting it at that moment. Okay, so echo diagnosis. So how do we prove a dissection? So in vascular, what is our diagnostic proof of a dissection? So if you're doing a vascular exam, what would we do to show and prove that we got a dissection?
With 2D and color flow, particularly the way the flow goes, like if it's all the way through or if it comes in and comes out.
Yes, good. So the most important thing first is 2D showing the intimal flap. Okay, if you don't see an intimal flap, then it's not likely to be that, or it's not provable. Remember that it can go circumferentially around it in a transverse plane, or it could be longitudinally. It will spread up and down the vessel also. So you want to show that in 2 dimensions, that intimal flap. You want to show the true lumen versus the false lumen. We want to look for any connections where it's torn through the intimal layer versus a hematoma that's a bleed behind the wall. These will often be dilated as well, so they'll also be aneurysmal. And then, of course, sticking color Doppler on, we're going to color Doppler it and see if there's flow going into it. We want to note if the flow is going the same direction during systole as the true flow is. And but again, in the thoracic, they can go the same direction. So you're not necessarily looking for opposite flow. We just want to see that there is or isn't flow going in, and any connections between it. Okay. Okay, they would probably require further imaging. So TEE, CT, or MRI would be very good at these. In the labs I worked in, they would typically bring them to CT if they found it. We're going to measure the dimensions. So you'd measure the aneurysmal areas just as you would a normal aneurysm. And the pitfall, or the place that we tend to make mistakes for false positives, is when they get these artifacts. So when we get a strong reverberation artifact, that reverberation from that wall may reverberate into the vessel. That will tend to move the same as that wall does. And you're looking at the flow to be proven to go in opposite directions of it particularly, but you're seeing that it's distinctly different movement than what that might be. So how do I get around a reverberation? How, if I think it's a reverberation, what do I need to do to prove if it's real or not?
Just another view.
Yep, another window. So go to a different location, move your transducer slightly, angle back through it. Turning on it, you can still sometimes get that same reverberation and you still think it's there. So I would suggest a totally different window if you can to help get rid of that reverberation. We certainly don't want to be sending people for MRIs and CTs and stuff and emergency surgeries based off a reverberation artifact. We could also get side lobe artifact and stuff from the sinotubular junction. So remember, a side lobe artifact will tend to extend your pixels and stuff out into the luminal area. So it may look like there's a flap of something going beyond that sinotubular junction. So just be careful that what we're looking at, again, isn't an artifact. And as we talked about, color Doppler, it can be on both sides. Down in the abdominal and probably the descending thoracic, it tends to go in an opposite direction of the flow coming in, but it can go the same direction, so don't be thrown by that. And then you can also use agitated saline will distinguish if it's a vein. So the other thing that we can run into, we'll go to the carotid, for example. So if I'm scanning carotid, my artery and vein are right next to each other. And sometimes you think you see this flap, and if you really are concerned about it, you can use agitated saline to help distinguish if it's a vein versus the artery. If it's truly in the artery, then you're not going to fill with agitated saline, since it's only a venous contrast. Another couple cool pictures. So many dissections have multiple tears, so it's not necessarily one convenient little place that it tears. It could be multiple areas. There could be multiple connections and not just one hole. Aortic involvement, or the arch involvement, should raise the possibility of head and upper extremity involvement. So obviously, if it hits that level of the arch, we're worried about it causing issues of flow to the brain in particular, but also to the limbs. The ascending can show clear true lumen because we see where the actual blood flows relative to the flap. The true lumen will expand in systole, and it's going to become more regular shaped or rounded because of the pressure filling up that space. It is often smaller than the false lumen. The false lumen is often filled with swirling homogeneous echoes. So if we're looking at it in 2D, we might see that swirling effect, that smoke effect or rouleau effect, especially as it's getting closer to clotting within it, which may happen. It may occasionally form thrombus, and it gets small fibrinous tags of tissue that tear away from the walls. It's sort of like our Lambel's excrescences and those adhesions and stuff that are forming in the pericardial sac that we talked about, there's going to be little strips of tissue that might be flapping into that space. Because remember, we're actually tearing away those layers, and when you tear anything away, you get little strips of tissue that protrude from that. Okay, and then the intramural hematoma. So again, this is a bleed in between the layers, which is really in the muscular layer of the vessel. It is an invariant of acute dissection. It propagates circumferentially and longitudinally, but it does not rupture. So again, it's going to spread up and down the vessel as well as circumferentially around the vessel, but there's no connection between it. Now, eventually, it might actually rupture, so that it could progress into that. From a patient's symptomatic standpoint, it's going to be the same type of presentation as a regular aortic dissection is. It's going to appear as a concentric thickening of wall more than 7 millimeters with no flow inside of it. So when we put the color Doppler on, there won't be flow inside of it. But you probably will see some, you'll probably see almost thrombus formation inside. Atheroma will have evidence of mild or of intimal thickening and possibly calcifications as well. Okay, so complications of and natural history. So pericardial effusion is one of those. So if we get into the ascending aorta and it gets close to the pericardial sac, we could rupture into that, causing a pericardial effusion. If it ruptured into that, what do you think our pericardial effusion would look like? Is it going to be anechoic and clear? What do you think it would be?
It'd be more echo dense.
Yep, because it's blood coming in, right? So we've got blood particles, blood cells, and stuff like that coming in. So it's not going to be that nice anechoic appearance. All right. We're always worried about side branches. So in particular, the coronary arteries. So if it goes past there, it might dissect into the coronary arteries, or it might the dissection flap might actually cover the ostium of that as well. We could have aortic pseudoaneurysms, and if it gets to the valvular level, we could also end up with significant aortic insufficiency, with that intimal flap actually protruding through the aortic valve, causing lack of coaptation. Okay, so again, the pericardial effusion is likely to be hemorrhagic. You may still get some mild effusion just because of the trauma that's going on as well. Anytime we get in any sudden changes of pericardial fluid, what is our big concern with pericardial effusions?
Tamponade.
Tamponade. So look for tamponade. Make sure that we're not getting signs of that. So what are the signs of tamponade?
Respiratory variation of the mitral and tricuspid valves.
Yep, good. So, and then we're going to see possibly right ventricular free wall collapse, stuff like that. So those are the ones you want to prove pretty quick. Again, that's also medical emergency. We're already kind of in a medical emergency though when you are having a dissecting ascending aorta anyway. And then as always, CT and MRI are better at determining the involvement of the actual side branches. Let me ask you this. Are there, because we always talk about this level of branches, are there any other branches in the thoracic aorta off the aorta?
The phrenic?
And if so, what are they?
Yes.
You have to feed the thoracic muscles.
Yep. Yep, so you have branches off. So you have the azygous branches that come off the back of the aorta. We often don't talk about those because we don't really see them that well, but note that there are branches out in the thoracic aorta in addition to our 3 head and neck and the coronaries. Okay, so AI usually is due to a stretching, but possibly due to the dissecting flap protruding again through that valve. Intervention and surgery is used to arrest further development or to stop it. They may have prosthetic aortic valve or aortic graft or possible prosthetic valve implantation afterwards. The ascending grafts that have coronary involvement, they might remove those and implant them into the graft. We're always going to, any of this stuff, we're always going to evaluate the diastolic and systolic function as well. Just noting these images down below here. So we've got these aneurysms down in the ascending. This one's got some stuff up into the arch with the head and neck vessels, just showing some of the grafting that can be done. As we saw in our presentation on prosthetic changes and surgical changes, when we have those conduits, those valve conduits and stuff, they might, that's where they might attach as coronary arteries in those types of procedures. Remember, the graft can be inside the aorta, like a stent type graft. It can be partially a stent, partially on the outside sewn together. There's all kinds of variations on that. Okay. In high volume centers, and those that do these types of things a lot, aortic valve is preserved in about 75% of the cases. So if they're good at doing the surgeries and we can catch them early, we don't necessarily have to replace the aortic valve, which is good. In low volume centers like Colville or Chihuahua, they're probably going to flight them down to Sacred Heart. Unless they, well, they might have to stabilize it first, I'm not sure. All right, so after surgery, the false lumen often persists in the descending aorta, and thrombus is also noted. So where there was an opening, it may have started to coagulate and kind of form, and it becomes more echogenic. Okay. Fenestration is used to preserve flow to the vital organs. So if it's covering up those areas, again, using that IVUS as a directional for that procedure and assisting in that. Again, fenestration is just poking holes through that membrane so that we can get flow across to those vital branches if they're becoming blocked by the dissection. All right, so atheroma. So as we get older, particularly with diabetes and tobacco use and stuff like that, we tend to increase our burden of plaque. So that's kind of an aging process and or lifestyle contribution, and sometimes genetics. So it's most common in the descending aorta and the arch. I forget who was telling me once, I think it was when I was doing my IMT training, this intimal medial thickness software training I was doing. The places, so wherever we get a bend in something, so if I've got a tube that's going out, okay, and I've got normal laminar type of flow, where I start to turn is where you start to become, develop issues along the walls, and that's where plaque begins to develop. So from the aortic, ascending aorta, where do you think is the first place that might develop plaque buildup or damage to the walls?
Brachiocephalic on.
Okay, so right at the arch, as soon as it starts to turn, that's the first area we're going to start to develop it. I think the second area that plaque is likely to develop is at the bifurcation of the iliac arteries, and the third most common place to develop plaque development is at the carotid bifurcation of internal and external. So those are the first three most common places to start developing plaque buildup. Okay, but anytime we branch, anytime we take a turn, there's a strong likelihood of developing plaque formation at those areas, and it progressively gets worse. So in the aging process, it's common to do that. So in the vascular world, we tend to do a lot looking at the bifurcation of the internal external arteries, carotid arteries. But I would suggest that if you're doing the carotid exams, to look carefully at the bifurcation of the brachiocephalic and carotid arteries off of the arch, because that's actually the first place it's likely to develop it. And I think there's a lot of carotid plaque gets missed. Stenosis gets missed because we don't really look at that area very well because it's difficult to get to. All right. So symmetric, crescentric or crescent-shaped, protruding or complex, possible mobile or pedunculated components. So in other words, we are describing the plaque formations we see. Is it smooth bordered? Is it homogeneous? Is it heterogeneous? Is it crescentric? Does it go around? Is it just kind of a little blip on the longitudinally. It's important to note, particularly if they are protruding, so they start to stick out and go into the to the luminal area, particularly if there's edges of any kind. Those types of things are concerning because it could break off, causing embolization. And or rupture to where we cause dissections to form. Smooth, slightly thickened areas of plaque are not nearly as concerning as calcified, rigid, and poorly shaped plaques. Okay, again, CT and MRI are also good at looking at those in more detail. They note here the contrast enhanced CT for penetrating ulcers. So looking at a plaque formation, if it's actually got kind of a divot out of it, and we can sometimes see blood dipping into that area where there's a break in the intimal layer, that's where this is going to be good at detecting, because those are much higher risk of dissection. All right, coarctations. So as the picture shows, it's really a constriction. It's in the location of, again, where our PDA attaches typically. So it's a pretty significant stenosis or coarctation. It's usually like a connective tissue developmental issue that restricted it from the get-go. It would be nice if they drew a pulmonary artery in here with the PDA connecting there so that you know that that's the area we're looking at. Having said that, it doesn't have to be at that location. Okay. So aortic pseudoaneurysm contained rupture with the neck. So coarctation is one thing of these miscellaneous conditions of the aorta. Pseudoaneurysm is another. What is a pseudoaneurysm? And where do you think we most commonly see pseudoaneurysms in the cardiac world? So first of all, what is a pseudoaneurysm? Kelsey
like
doesn't have to answer all these because she's vascular, and we've all talked about them.
Sweet.
So what is a pseudoaneurysm? So first, what's an aneurysm? Stretching, right? It's just big stretching. Pseudoaneurysm meaning false aneurysm. It looks like an aneurysm, but is not. These are typically because of a connection that starts to protrude outside the main layers of the vessel wall, and it forms a pouch of fluid outside of it that's has a strong likelihood of rupturing. So that's what it is. Where do you think the most common place we're going to see it is in the cardiac world? Do these form naturally? Okay, when we got pseudoaneurysms in the heart, how did that form? What was it associated with? What pathology?
Would it be with an MI?
Okay, so yes, and it happened in an MI there. So we weakened the wall. It got a bit of a tear in it, got some fluid behind it. That caused the pseudoaneurysm to occur. In vasculature, they don't just naturally come out usually. They can, but not usually. It's usually because we poked something. Okay, where do we poke something that is going to puncture an artery that could cause a pseudoaneurysm? In the
Common
cardiac.
femoral.
Yeah, so mostly the femoral, but it could be other areas too. So when they do cath lab procedures, it typically takes about a 6-hour recovery because they're trying to get that artery to heal up again or put a plug in it so that it doesn't rupture. If we do it too early, we can form pseudoaneurysms from that puncture site. Okay, we can also form inadvertently connections between the venous system and the arterial system, creating an AV fistula, which is also problematic. So those are things that we're going to see in the cardiac world. So pseudoaneurysms you're going to find are fairly common for you to scan in a cardiac lab. Okay, and it's typically going to be in the right or left groin area. So another thing could be aortic trauma. So blunt chest trauma cause tearing, usually at the ligamentum arteriosum. Okay, so if we get a sudden compression, a sudden jolt or something, that can cause a trauma to the aorta that causes bleeding. It is uncommon to document partial or complete transection. What is a transection? Severing. Okay, so like you severed the aorta. Okay, Obviously, that's a major emergency, and we're typically not going to be doing echoes on those people because they're almost immediately in surgery if they can even get there. And they are often fatal because it's a very rapid bleed out. Hematoma. So in adventitial or the periadventitial layers, often distorts the shape of the aorta. So that goes along with our dissection comments about the hematoma developing in the layers of the wall. Trauma might cause specific site injury to the aorta, so where it specifically hits. Other possibilities are rupture of the Valsalva sinuses due to that right atrial formation. And it can form an aorta vena cava fistula. So it could create a connection between those two structures. We get a high volume turbulent flow into the IVC if that's the case. These are nice graphic pictures. The one guy there that's getting punched, he kind of looks like that that boxing bag. I don't want to say dummy, but the dummy that you usually see. That's what it reminds me of. All right, and then other things. So while the aorta tends to have a progressive disease process because of lifestyle and genetics and things like that, plaque buildup, those types of things, there could be trauma, obviously. But we can also have infections that affect it. So they're rare, but they can arise from an area of any plaque buildup or possibly at the PDA if the PDA is open. Remember, PDA is just like a valvular jet where it's irritating and stuff on that tissue, and it just gives it a place to seed an infection if we have a bloodborne infection. It can manifest as a pedunculated mobile mass. We could have syphilic aortitis, so an inflammation of the aorta by syphilis. Aortic thrombus, more common in proximal descending aorta and associated with peripheral embolization. So if we do get it in the aorta, then we are concerned about chunks of that breaking off and going down the legs or wherever it goes. So that's where you might get the trash foot or blue toe syndrome, stuff like that, where it breaks off and goes downstream. That's problematic. It's seen with highly mobile echodense masses within the lumen and appeared to attack the aortic wall or attached to the aortic wall by a fairly thin stalk. I remember this one case at Inland Imaging we had. I didn't scan it, but I got to see it. It was in the vascular lab. Somebody had this carotid plaque, so it's up in the neck, and we called it the goat tail because as my tube is sitting here, I've got this piece of plaque that's protruding out into the lumen like this, but on every systolic beat, it would do this. We were watching this plaque go back and forth. I mean, we were just waiting for it to break off and go downstream. It was pretty crazy. I've never seen anything quite like that. You don't worry so much about those in the venous. I mean, they are concerning, but if you're seeing that, particularly on a vessel going to the brain, that's obviously a bad thing.
Did they have an indart?
I don't know what they did after that. I just remember we kept the patient laying on the bed until we contacted the doctor to see what they wanted to do, because that's not a patient you necessarily want to be walking around town. And it's like, don't cough, don't, just stay calm.
But like prior to your finding, did they have an indart?
No, I think this is just a natural plaque formation where it was obviously starting to break off, and it was probably ulcerated and came out. But it was crazy.
I saw sadly enough, by one of our surgeons, I saw that type of movement with either plaque or intima so often.
Oh yeah, it's probably the surgeon. So when they do an endarterectomy, so they'll go in and actually cut that layer and strip it out, but they leave sections there. And if you get where that ridge of tissue is that they cut off, if that blood flow gets underneath that, it's now going to start to create a tear, which makes sense to lift that up and start having that flappy little portion. It's really the beginning of a dissection, unfortunately. So yeah, the good endarts. We had a doc in Colorado Springs, our first vascular surgeon. Her surgeries were ugly. Like she never gave us maps of anything she did. We just kind of had to figure it out on our own. But she left a lot of plaque in, And the other guy that was there, I mean, it was like it was naturally developed. I mean, it was just a beautiful endarterectomy. I mean, those are just, I loved scanning his stuff because he's just such a beautiful surgeon. The other one, you know, it was really difficult to scan because there's still a lot of residual calcified plaque and stuff left there. There's ridges of tissue, which are just not good when you're doing those types of procedures because you're going to have inflammation and development of stuff and progression of disease after that too. Yeah, your surgery makes a big difference.
Yeah, I remember the first time I saw it, I was relatively new. And I was like, yeah, I'm pretty sure I see an intimal tear. And they're like, oh, okay, who did the procedure? And I was like, oh, is this person? They're like, oh yeah, that's pretty common. I was like, oh my gosh.
I would hate to be his representation for medical malpractice. All right, Takayasu's arteritis. So again, this is an inflammatory type of disease that affects the aorta and proximal branches. So head and neck vessels included, and coronaries. It occurs in patients younger than 40. It's marked with irregular thickening of the aorta and its branches, and it will look similar to atherosclerotic disease. So if we're looking at that intimal medial type of a layer, it's going to look like plaque. Very rarely, other forms of arteritis can affect the aorta as well, such as giant cell arteritis. So there's different forms of arterial inflammation. So this one in particular affects more of the proximal segment of the aorta, which happens to be close to the heart.
And two, isn't this the one where it's like usually Asian young women?
Yes, it is, typically. That's probably associated with the name as well, but yes. And then remember the other disease that affects the coronary, creating aneurysms. Remember what that one's called? The proximal coronary arteries. What was that one? If we get them dilated and aneurysmal. I'll give you a hint. Motorcycle. Kawasaki's. Okay. And that is diseases of the aorta. So a big concern with diseases of the aorta is the closer they get to the heart, the more problematic it becomes. So know your classifications between the DeBakey and the Stanford methods of classification. Again, looking for those intimal flaps, looking for aneurysms, even aneurysms and misshapen sinuses of Valsalva. Those are problematic. If we get significant regurgitation in the aortic valve, you want to be looking at stretching of the annulus, but you also want to be looking for these aneurysms because it might have a, flap of tissue coming through there causing that. Look for your sinotubular junction. It should come and taper down to normal, and then gradually ascend to the tubular shape. If it doesn't come down off the sinuses Valsalva and it's dilated at the sinotubular junction, that's not normal. And is an indication of some type of a preceding stenosis. Not a lot else to say. I think any questions about the aorta? Yeah.
Going back to the fibrosa aneurysm, I think I missed what you said. Did you say it would be caused by endocarditis, right? Like it can be caused by it?
Let me jump.
I think it's slide 17.
So exceptionally rare forms in the skeleton communicates to that. I think it can. Let me just look that up real quick. So fibrosa aneurysm. That was after sinuses Valsalva aneurysm, right? We'll do this.
Yeah, because in the book it doesn't say if it's caused by endocarditis, but I feel like I heard you say it maybe.
I think it could be. Let's see.
Oh yeah.
Yeah, so it is aortic valve endocarditis. So this is from the NCBI. So this is by the NIH.
Wait, it said something else in front of that. Oh yeah.
Yep.
Oh, it said pseudoaneurysm of the mitral aortic fibrosa. That's a different name.
Yeah, so pseudoaneurysm. So yeah, so it is a pseudoaneurysm or intravalvular fibrosa. It's an uncommon condition consisting of pulsatile cavity. So it's pulsatile in the mitral aortic junction, communicating with the left ventricular outflow tract. The most frequent cause is aortic valve endocarditis, particularly in prosthetic valves. Okay.
Okay, thank you. Sorry, I
Yep.
totally could have just Googled it.
No, it's good. It's good for all of us to hear. Dr. Google, right? Just make sure Dr. Google leads you to a place like the NIH type sites like this that are reputable.
And not WebMD.
Not WebMD. No. Dr. Google, love it. Oh, there's some good pictures there. In fact, that looks like exactly the picture I have in my slide. This is probably where I got it from. There's another couple there. Cool. Any other aorta related questions? Then I think we're good. So this test will be open. So this is the lecture 1. So this won't be till Wednesday. And so let me bring up the schedule real quick. I don't think we need to do anything until Wednesday, which will be masses and tumors.
So no lecture Tuesday?
I'm just verifying, but I think we will not have lecture Tuesday. Give me a second to load.
I think a lot of us signed up to scan that day because you said we weren't going to have lecture.
Yeah, so we'll cover masses and tumors then next Wednesday. So the exam for diseases of the aorta won't be until the 2nd. And that's the day we'll also start the masses and tumors. And then we will test on the masses and tumors though on the 3rd, on Thursday.
Hey, Scott.
Yeah.
Can you see the ligamentum arteriosum on echo?
As a ligament, no. You might be able to on transesophageal, but on transthoracic, it's going to be very unlikely.
Would you see it if it wasn't a ligament and if it was PDA?
If it's PDA, we should see it, yes.
Okay. Just because colorful?
On pediatric, you should see it basically connect to the aorta. Where we're going to see it on echo is going to be like your parasternal short axis view with the pair of pants off the right and left branches of the pulmonary artery. Let me see if I can get a clip of it.
Will you see it coming through like from almost the aorta there, like through the sinus?
See if I can show you. It's going to be coming off one of the branches and it's going to be looking just like the pulmonary insufficiency does.
Oh, okay.
See if I can find it as a clip. All 2D. Here's one right here. That's not a clip, but this is parasternal short axis. Can you see that? So this is actually, they've cut off a lot of the right ventricle here, but here's aortic valve. This is pulmonary valve up here. And you see how we're seeing a candle flame type of appearance, but it's coming from way down here.
Yeah.
So this is the right branch, this is the left. So this is the PDA right here. So that's open, leaking back. So in your parasternal short axis view, you want your color to cover this area where the pulmonary artery branches off, because that's where you're going to see your PDA, at least in an adult echo lab. I'm sure there's other views that Tammy would do in their lab. But this is
Okay.
what we're, I was hoping I'd get one in a video clip, but apparently not that one. Let's see, that's probably, this is another one. That's actually a pretty cool one. This may not be a clip, but notice here how you have pulmonary artery up here, and you've got your candle flame there, and you've got a deeper candle flame down here. So
Is
if your
that from
candle
both?
flame- if your candle flame looks really deep, you want to be looking and considering a PDA.
Okay.
Is that high pressure is coming from the aorta into the pulmonary artery, which is lower pressure there. So the aorta is high pressure, that's low pressure. It's going to be coming in typically during. You're going to see it probably mostly during diastole, because that's when the flow in the pulmonary artery is stagnant.
Isn't that what a branch stenosis turbulence would look like though too?
If it's branch stenosis, it's going to be more into the branch, but it's going to be turbulence, but it's going to be going out. This is a candle flame flow. Like this looks like a regurgitation. So that's only going to be during systole. But yes, it will be aliasing, but it will also be down lower into the branches themselves.
Okay, right, duh, it'd be going the other way, going blue stenosis. Okay, got it.
So that's why for me, I'm not so big on having a super tiny color box all the time. I like to have the long ones with, the width has to be narrow because you want your good frame rates, but I want to see stuff, before and after the valve, because this is where you pick stuff like this up, because you don't always look for stuff like this. If you had a small color box that was just in this area, you don't necessarily look down here. So I like having my color box like that. Same thing with ventricular views when I find like mid-cavitary gradients and stuff like that, like with hokum, and just hypertrophic cardiac disease. There's another picture there. So proving where it comes from, it's coming from down deep. That's your kicker. In fact, on this one, you can see that this is actually the descending thoracic aorta there. And it's actually connecting, and you can see that connection. You could actually pulse wave or even put a CW through that. Kind of cool. I like this one. This is the money shot of the day right there. I think that's a cool one. All right, well, let's leave it on that note then. Does anybody else have any other questions? All right. So get that money shot when you're showing the doctor. That's what we want to see. That's good proof right there.
Yep. Thank you, Scott.
All right, you guys have a great day.
Thank you.